So 2012, Khosla said 80% of healthcare can be automated. And it's funny because all my friends in business school were like, that sounds really cool. We were in San Francisco at the time. And all my friends in medicine were like, that's blasphemy. During COVID, we saw hospitals that didn't have beds because they were taken up by COVID and elderly patients. They essentially could not do elective surgeries. Elective procedures generate like 70% of the revenue for healthcare systems. And so they basically lost their cash cow, and there were entire health systems and hospitals that just went bankrupt. Most hospitals have one physical therapist for every 30 patients. Most nurses don't have time to mobilize their patients 3 times a day. If they're lucky, maybe once a day. And so I think we wanted to create something that like everyone, every elderly patient, if they could just keep moving, like they could actually go home in 3 days. We wanted to make something that was accessible to them. There was a president of a large healthcare system. They literally went to their shareholders meeting and said, our number one priority is mobility because it impacts everything from operations to finance to costs to staff.
Welcome to Autopilot, a podcast where we discuss the past, present, and future of AI and automation.
From Atlanta, Fulton County.
That's one small step for man.
We explore how AI is creating and disrupting large industries in conversations with top founders, investors, and historians. I'm your host, Will Summerlin. Let's dive in. Thomas, welcome to the Autopilot Podcast. So today we're going to talk about the opportunity for AI in healthcare, your experience as an ER doctor, your experience as a founder of an AI healthcare company. But before we get there, why don't we start with you? Can you share your story, just where you grew up and how you became an ER doctor?
Absolutely. Thanks for having me on the podcast. Like I said, I've, as a founder, as an ER doctor, we listen to a lot of podcasts. So happy to put some content back into the universe. Yeah, so I am an emergency medicine physician in Boston's largest healthcare system. My background, I've always had a few loves in my life, including business, technology, and sports medicine. For business I did my MBA. I left med school temporarily to do my MBA at Wharton. I was really lucky that this was in 2012. It was the first year that they opened up a campus in San Francisco. So I basically skipped a lot of classes and took the Caltrain down to the Valley and worked with a bunch of startups. Yeah, I worked for a brief period as a consultant with McKinsey & Company, where I focused on hospital operations and supply chain. And then I also worked in mobile health for Quest Diagnostics, which is a large Fortune 500 healthcare company. As far as, technology, when you move out to San Francisco, you kind of catch that bug. And so, I've been, obsessed with doing startups since college. I did my first startup in college doing microfinance. We ended up partnering with the Clinton Foundation and doing things to help with poverty alleviation. Even at Wharton, I worked with a startup that did a vaccine supply cold chain off the grid, had some partnerships with UNICEF. And I guess my last love is sports medicine. So, when I was a kid, I loved sports. I was the kid that was watching the Gatorade commercials of the athletes on the treadmills. And I think that kind of just inspired me to study exercise science in college. I went to Rice in Houston and I basically got to spend 10 to 15 years working with the most elite athletes in the world. Got to work at the 2008 Olympics in Beijing, got to work with some elite basketball teams, including Duke and UConn, got to work on the staff of the Houston Texans of the NFL. And so, yeah, I think, ER doctors are known for having like intellectual ADHD. And I would say that that's probably pretty characteristic of me.
I'm curious, like one of the things I spend a lot of time doing is trying to recognize patterns among the best founders. I'm curious, you worked with a bunch of the best athletes in the world. Did you see any patterns that were shared or traits that were shared among them?
Yes, they are not normal people. And I think it's kind of like foolish to think that they are to get those types of results. I think probably the most telling thing is in my medical school class, the top 3 students were all Division I athletes. I think one was a track runner, one was a football player, and the other one was like a tennis player. And I think it's a telltale sign that like, when you spent your whole life being regimented, like you're just going to have a different work ethic than a lot of people. And in terms of organization, they were always like gym, library, class, repeat. And I think when the rest of us were, like kind of blowing off some steam or going out on boats and stuff. So I think you see that work ethic going to Duke. I'm a big Duke basketball fan. Seeing those athletes, you have a lot of the elite athletes in the world because they have the Coach K Sports Medicine Institute, where pretty much anyone who has any major injury, they'll go to Duke. And so like Kobe has been there, and just seeing like the work ethic from those guys, it's really something that like takes you back. And so I think it makes sense why people, like get the outcomes that they do.
It seems like one of the traits that's most common among great founders is just grit. It's really hard to build $100 billion company. And in my prior firm, we were among the largest shareholders of a lot of these big public companies that started as startups. And so got to know the founders. And I remember one of them told me one day, like, you have to be completely irrational to build a 10, 20, $30 billion company, because if you're doing well, like, you have the opportunity to exit along the way, right? And a rational person, given the opportunity to sell their company for $1 billion and cash out a couple $100 million and go retire on a beach would take that. But there's something about the people that want to keep pushing and pushing and pushing. And the same founder said something interesting, which is like, the biggest misconception is that it gets easier as you scale. Like, it actually gets a lot harder. Like, you think, oh, I'll just get to 10 million in revenue and hire VPs and then just kind of chill. And it's like the opposite. It just gets harder and more complex as you go. And there's something about the people that have the grit and the fortitude and probably a chip on their shoulder that just keep pushing and pushing and pushing. It's probably the same thing in athletes.
Yeah, no, I absolutely agree. And I think, like, I have 2 kids. I have 2 girls, ages 3 and 6. And, my wife and I always talk about, if you could impart like one skill or one value onto your kids, like, what would it be? And I think there are obviously a lot of great values that you want to impart on your kids, to be kind, generous people. But I think for me, if I had to pick one, it would be like that grit, like being comfortable being uncomfortable. Because I think my personal perspective is that some of the best things in life are forged through fire. I came to this country as an immigrant. I came when I was 5, and my parents worked, like my dad worked. He took a huge career, demotion to work like blue collar jobs. And you kind of just see like what working hard means, but also like what the good that can come out of it, of like not giving up. And I think similarly, like in the ER, a lot of times, like, I don't, some of my shifts, which I still work just because it's nice to have a finger on the pulse of the healthcare industry. Like, I work on a hospital on an island, and there's nothing. I have no help for like 45 minutes. I think people have come in with shark bites. People have come in with gunshots. Like, there's nobody else. And so I think that ability to kind of like tough through things, you learn things about yourself that can be empowering in other aspects of life.
Wow, that's insane. So it's just you and a patient with like a shark bite or a gunshot wound?
Yeah, like, I'm the only critical doctor that can handle stuff like that for X miles. But I think people who go into ER are kind of like founders. You have to be kind of crazy to run towards like the fire and the explosions that everyone else is running away from. I don't know. There's something about it.
I feel like even just getting through residency is grueling. It's sort of like, it's like the Navy SEALs have buds, right, to like test whether or not you can make it. And it seems like residency is sort of the doctor's version of that.
Yeah, I think it's just by necessity. Like, you think about, like, people talk about like 10,000 hours to master something, and what more important thing is it to master than like when you have patients' lives in your hands? If you're a surgeon, that's why surgery residencies are even longer, because they're 7 years, because you're literally cutting into someone where 2 millimeters off, and you cut the carotid artery, and the patient bleeds out. I think people go through residency. I think, like any hard thing, it's nice when you have a cohort of people that can share it. But I don't think it's designed to be easy on purpose.
What's the craziest thing you've had to treat as a ER doctor?
There's a long list of stories, and I think most ER doctors have, like, I think for us, like, the wins and the saves stay with you longer than like the losses. Like, obviously you feel terrible if bad things happen to patients, but I think what keeps you in this job is that you're always looking for that next great case, that next great save. And so, I've been lucky enough, like, I trained at Duke, which is a large academic medical center in the South. And I think it's one of the few that, like, you see a lot of medical complexity, like, like, you, similar to Boston, like, people come in from Saudi Arabia to get like their 4th heart transplant. But, Durham, unfortunately, historically has been like a tough city. There's a lot of violence sometimes. So there's a lot of trauma. And you don't always get that mix of like intellectual stuff with the trauma together. I think for me, probably the craziest case is a few years ago, I had to basically steal an ambulance to make sure that my patient didn't die. There was I think, 26-year-old at like 6 in the morning that basically the report is that he was in a police chase on a motorcycle and he basically crashed into a garbage truck going 150 miles an hour. And so most of the times you don't get those calls because those patients are dead in the field at that speed. But he was alive. They brought him in. I immediately called for every unit of blood in the hospital. It was fortunate that like I had another ER doc coming in to relieve me. It was a shift change, but basically the crux of it was that this guy needed to go to the operating room, and we were a smaller hospital, and the closest level 1 trauma hospital that I work with is 45 minutes away, and this was a Monday morning rush hour, and so we needed the helicopters. I called them to say, I need you to get the birds in the air, and it was kind of overcast, not quite rainy, and so they said the birds are not available. And so I was like, if this guy stays here, he's going to die. And so at one point I ran out into outside the ER and into the road, and there was an ambulance, and we flagged it down. And I was like, I need to borrow your truck. And he's like, I'm not qualified to transport this. I'm like a basic, like I'm not even trying, but then, so I said, well, why don't I bring like a few of our nurses and I'll ride with you? And now technically we are life flight, which is the highest level because you have a physician on board. So we basically, I guess, commandeered an ambulance, got this 23-year-old to where he needed to be. The surgery team was waiting for me because these are my colleagues. He got to the operating room. He was in the OR for many hours. And then 3 months later, he walked into the hospital with his mom and they gave us a hug. So
Wow.
that was good.
That's incredible. Yeah, it is kind of like being a founder, I guess, in a way, except for the stakes are way higher. Obviously, you're dealing with people's lives, but like you just got to do whatever it takes.
Yeah, to some extent, you're asking for forgiveness instead of permission.
Yeah, 100%. That's absolutely incredible. All right, well, we could talk for the next 45 minutes just about, I'm sure, your war stories. But maybe if we like zoom out for a second, like you've seen the healthcare system from a few different angles, right? As a doctor, as a founder, selling into the healthcare system, as a consultant at McKinsey.
Yeah.
What are the biggest problems in healthcare? And you hear people talk about healthcare is broken, it's too expensive, we need to fix it. But I haven't actually heard somebody dissect like where are the biggest problems or inefficiencies in the healthcare system?
So, I think as an ER doctor, I do have a really unique perspective on the healthcare system, both in terms of breadth and depth. So we see every specialty, and within each specialty, we see like every level of acuity, right? So I'll see cardiology and GI and neurology, but within each department, I'll see like the patient who has a little bit of chest pain versus the patient who's in cardiac arrest and needs a heart transplant. So I think I think fortunate asset to being a founder for a digital health company is that like, I feel like I do have some good perspective of everything, along with how the different components coincide from reimbursement to the power dynamics and things like that. I would say people always talk about the top 3 issues in healthcare, probably cost, access, and quality. I would say like access, I do see a lot in the ED. I think, unfortunately, there's just a lack of both inpatient and outpatient access, both from inpatient beds to outpatient appointments. Part of that is from the lag of, people who didn't seek care during COVID and just kind of, hitting the backlog. I see it a lot because it overflows into the ED. I do think that some of the other issues, one of them is that contributes to that is this mismatch between patient understanding / education and expectations. And so I think as doctors, like we do a really bad job we focus on the clinical stuff, but we do a bad job of explaining things to patients. If what you need for a patient to make the right decision is that understanding, then they're essentially doomed to make the wrong decision. And that leads them to seek care in the wrong settings, which creates inefficiencies in the system, increases costs. For example, I get a lot of patients who, come into the ED in the middle of the night, parents with young kids. I've been one of those, and they call the hotline for their pediatrician trying to do the right thing, and they just say, go to the ER. And I think some of those can be avoided. And I feel for those patients. I don't blame them. I would do the same thing I remember being a first-time parent. But I think just like in people not understanding, like maybe sometimes outpatient doctors not understanding like what every setting is capable of, us not understanding what they can do in a clinic and clinics not understanding what a hospital can do. ERs are meant to manage acute issues, but we can't fix things necessarily that have been going on for like 3 or 4 years. So I think that gap between understanding and expectations is one of those problems in healthcare. And I think the last one is probably that I see every day is the hidden burden of knowledge. So there are infinite tech companies like ourselves that are trying to digitize things, and that's probably good that that knowledge is being digitized. But then the question is like, who is responsible for that knowledge? Who does that responsibility, that scarlet letter, that hot potato fall on, right? Because this is not knowledge that is inconsequential. This is like something that can be life or death, or in worst cases can be retrospectively pulled up in like a lawsuit case that like someone did not follow up on this, that radiology reading, that one line that says maybe this is a mass. So I think as our healthcare system grows, as it becomes more digitized and advanced, like that burden of knowledge is starting to become hard because it requires more documentation. And I think the providers who are supposed to take responsibility for that knowledge have been a little hesitant. And so that is one of the issues that people probably don't talk about very much.
Yeah, that's a super interesting perspective.
Yeah.
On the knowledge side, just to start there, it seems like if we're kind of intersecting AI and healthcare, it seems like one of the great potentials of AI is that, a very large AI model can just consume and essentially remember more information than a human, right? Like you can basically take everything a human learns in a PhD program and train an AI model on that data set in, a couple of days. And in healthcare, it seems like, as a doctor, like I would imagine that you have a really good grasp and understanding of things that are somewhat common, but when things more esoteric, like perhaps that's an opportunity for AI. Do you think that's true?
It's interesting. So 2012, I think it was Koslas. He made headlines when he said like 80% of healthcare can be automated. And it's funny because like all my friends in business school were like, that sounds really cool. We were in San Francisco at the time. And all my friends in medicine were like, that's blasphemy. I don't know if it's 80%, but I think a lot of it is. And it's been 12 years now. And I think the companies that have come out have basically proved that there is a lot that can be automated. I would say when I dissect that down to where AI is applicable in healthcare, and again, I am not the expert on this, but I think some of the common threads I see are that it's good for tasks that are predictable, repetitive, and high touch and low risk, right? So like the one time I have to resuscitate a pregnant woman who's in cardiac arrest and do an emergency section, probably you're not going to outsource that to AI. It's just not frequent enough or low risk enough. But there are tons of tasks that do fit those qualities of predictable, frequent, and low risk. And I think you're seeing the companies that have emerged do those things. So I think some of the first things are the administrative tasks, right? So billing, coding, scheduling. We had ZocDoc, and then now you have endless companies that do that. I think drug discovery is one of those where you have to go through thousands, millions of permutations to find like that one combination that might work for this patient. So that's a great thing that IBM Watson really became famous for using AI to do. Chronic disease management is one of those things. Diabetes and chronic kidney disease. There's tons of companies like Omada that are making a killing doing that. Some of the companies I've liked is like care navigation. I think there are some untapped, buckets. I would say like information retrieval at the point of care. There are tons of startups that will, that are like dictation and note taking, but getting the actual information, like, and having that like where you're standing in the hospital or in that room, I think there are things that could be developed. One of my former Wharton classmates has like a version of a documentation software similar to a bridge, but they basically make it tailored to the ICU teams, and they customize everything so that like you have that information right then and there. And I think the other thing with automation is like therapeutics, right? So diagnostics is, I don't want to say it's easy, but it's generally easier, but like to actually fix people, right? The last few years, obviously a huge model with using digital psychiatry care, mental health care, because that is an inherent type of care that you can do virtually. But, for physical therapy, some of the things that are hands-on, those are the areas that like we're trying to figure out, like, how does AI factor in?
Yeah, and we'll get to enabled health, your company, in a second, because it fits in that category and I think is solving a huge problem.
Yeah.
Before we get there, I'm curious, like, what are areas that people think can be automated from an outside perspective that from an inside perspective you look at and say, like, there's no way that AI is going to do that?
So I think part of the reason why therapeutics is hard is that people make, from my perspective, both physicians and patients and nurses, like we we use data to make the decisions that our hearts want. And so like the understanding of risk and making decisions based on risk in and of itself is like a science, right? So like I can go up to a patient and say, you have a 8 millimeter kidney stone, and we can either let you pass it, we can either do surgery to take it out, or we can use some ultrasound to blast it. And you're going to get like 1,000 different answers, and I think it's just because everyone's risk threshold is different. And that's the one thing that like, that's the other half, right? Like the doctor gives the first half, like we tell them what the options are. We try to do our best to educate patients, but it's ultimately the patient that makes those decisions. And so I think that's why behavioral science is this burgeoning field. I mean, you think about like how successful Netflix has been in terms of knowing a person's preference. It's like something like that would be beautiful. Like if you knew not just the objective numbers and probabilities of certain outcomes and diagnoses, but also what that patient's risk threshold is. That's something that we try to do as an art, right? We try to like, get a lay of the room and see like are they a super anxious person? Are they like generally pretty chill? I think that is why just being able to diagnose and treat someone is not as straightforward. But I think there's value, right? Because it's like, as a startup, right, you never have complete information or knowledge and you have to make decisions. And I think as an ER doctor, that's fortunately something that we're trained in, is we have to make 1,000 decisions a day, of which many are life-threatening or life and death with incomplete information. And I think it's just a testament that like, don't let perfect be the enemy of good. Like if you can get 80% there, like that's okay. Like if AI can automate 80% of healthcare, that's 20%. That's a lot less than humans have to do.
100%. That's a great framing. Now let's talk about enabled health. So tell us a story. Like, what problem were you trying to solve? How did the company come together? What are you doing now?
Yeah. So, Enabled Health is a digital health company that uses virtual exercise to solve this bottleneck of patient deconditioning in hospitals. And it really started as a bunch of clinicians, myself, a physical therapist, trying to solve a problem that we were seeing every day and that I have seen in every single hospital I've ever worked in. So deconditioning is basically this phenomenon where just, every patient that is admitted to the hospital is admitted to a bed, and they spend a lot of time in bed, usually like over 85% of the time. And so for me and you, like that would probably not be a huge deal. We might even think of it as like a vacation. But I think if you think about, most patients in hospitals are elderly, they're your grandparents, my grandparents, my parents. Like doing nothing for 3 days can have like a really rapid effect on their body in terms of causing muscle atrophy, decrease in like aerobic capacity to walk, balance issues, delirium. And so this is something that I've seen affect a lot of my patients. And I think Enabled Health started, when I kind of connected my McKinsey brain and, the exercise physiology brain with the medical brain, and realizing how this specific non-sexy problem like affects so many things downstream that affects hospitals, and was affecting my ability to do my job. I think COVID exposed a lot of things. It exposed, infrastructure gaps we had in our health systems, shortages in nursing that were actually kind of like looming, but kind of just blew up during COVID and we didn't really do much about. But I think one thing that exposed is that like when patients are staying twice as long in the hospital, like, and hospitals don't have beds, that intrinsically affects their fundamental ability to do their only job, which is to take care of patients. Hospital beds are their most valuable resource, right? Beds are needed to take care of patients and they're needed to generate revenue. And if you don't have beds, that's like a hotel that doesn't have hotel rooms. So your business effectively shuts down. And I think during COVID, we saw hospitals that didn't have beds because they were taken up by COVID and elderly patients. They essentially could not do elective surgeries. Elective procedures generate like 70% of the revenue for healthcare systems. And so they basically lost their cash cow, and there were entire health systems and hospitals that just went bankrupt. And so I think obviously like we started out like trying to fix a problem for our patients, but then we also realized like there's a very real business case to be built around this.
So what does enabled health do? If you have a patient that's stuck in a bed for 3 days and they're at risk of muscle atrophy, how do you guys solve that problem? How do you prevent that?
Yeah, so I think we realized that like mobility doesn't have to be complicated, and that lends itself really well to AI and automation. We talked about the things that AI can do, and so things that are simple, low risk. We essentially use AI and automation to democratize access to mobility training in a way that's scalable for hospitals. Because right now, and what we've seen is that the key rate limiting step, the bottleneck, is staff and human personnel, right? Like if you had infinite people and you had 5 people per patient, you could make that patient get better much quicker, but you don't. Most hospitals have 1 physical therapist for every 30 patients. Most nurses don't have time to mobilize their patients 3 times a day. If they're lucky, maybe once a day. And so I think we wanted to create something that like every elderly patient, who you knew, like if they could just keep moving, like they could actually go home in 3 days. We wanted to make something that was accessible to them. And I think about like my grandmother, she's 83. She has rheumatoid arthritis. On days that are humid, like her knees swell up. She basically can't walk very well. And like the thought of like her going into a hospital, because she's very independent otherwise, like she's always tagging along on any kind of shopping trip and stuff. She's great. And she was a huge part in like raising me. Like the thought of her going into a hospital and like not being able to return to like an independent life when that can be preventable is like something that like was what we started with. So we are not a hardware company. We build software that uses computer vision. It runs as an application on off-the-shelf iPads. And we basically give hospitals like a fleet of iPads for every unit, every floor, that they can move around to different patients. And the iPads function like like a virtual physical therapist or a virtual personal trainer. The things that we do, it engages patients in targeted strength and conditioning for muscles, for balance. And so like, we're not saying that we are physical therapists and we're not nurses. We're somewhere in between. And basically, we keep patients moving with, every patient starts with in-bed exercises just because safety and fall risk are huge things. And then as they progress in their strength, as they demonstrate their strength and stability, they can move to in-chair exercises. But the goal is to have them be doing something instead of doing nothing during their whole hospital stay.
Seems like one of the problems or challenges is ensuring that people are doing the exercises correctly. My fiance is actually a physical therapist, and like she'll give me an exercise and I'll go to the gym and I'll do it. Like, why does my back hurt? And then, later that day I'll show her. She'll be like, oh, you're doing it wrong, idiot. And like, I'm curious, like if you have a patient in the hospital and you assign them an exercise, how are you ensuring that they're doing it correctly?
So luckily, like we are training patients for like general tasks. These are not the patients that like just had their rotator cuff repaired that they have to do exactly 15 degrees of flexion and abduction. We're basically training people so that they can do the basic functions of living at home by themselves. Fortunately, like all of our patients can use essentially like 80% of our exercise library, which encompasses lower extremity like thighs, quads, hip flexors, core, arms and legs, just like things that you need for basic tasks. And so like we do use computer vision to authenticate that they are doing it, and we can assess like range of motion and stuff. But I think for us, what we've learned, what my insight as a sports, with a background in sports medicine, is that it's not like when you're going to the gym, and it's not how much weight you can lift. It's not even necessarily how many reps you can do. It's how often you can just activate that connection between a nerve and a muscle, right? Because we know that muscles, when you stimulate them, like they can grow, and if nothing else, they can at least stay the same size. And so what causes muscle atrophy is just the lack of stimulation. It's that car that you haven't driven in your garage for like 10 years, right? Versus if every every year you just turned it on or, gave it a jump, like you'd be fine. That's kind of what we're doing is if you can maintain that neuromuscular stimulation and over the first 3 days, like most of that deconditioning doesn't happen.
Why do hospital systems use this technology versus like just having PTs go room to room and exercise patients? Is it the cost of PTs? Is it the limitations on the size of the labor force? Like why is technology taking hold here versus human labor?
Yeah, I mean, I think in an ideal world, I would love to have one PT per patient, but I think it's like literally the exact opposite now where I think so I had a friend at Wharton, Abu Zaid. She's the founder of Incredible Health, which is a very successful like nursing hiring platform. And I remember like in those early stages when I was in residency, we had some chats. And I think one thing I always admired about companies like hers are that she looked at like what are the trends and the tailwinds in society that are going to be impactful in the future. And I think for us, like we know that there are two tailwinds that are going to make this mobility gap worse. One is that the elderly population is rapidly aging. The baby boomers haven't even reached their peak, and it's a population that's going to double in the next 20 years. Like, I don't know any other segment of the population that's going to double in 20 years. And so that's terrifying because right now we are already struggling to take care of the elderly patients in our hospitals. So that is one trend. And then the other trend is that at the same time that the elderly population is growing and aging, our healthcare workforce is going down by a lot. Countless articles in the news about, burnout and nurses retiring, and we're not replacing them at the same rate. And so what kind of helped me start the company / kept me up at night is like trying to figure like, what are we going to do in 10 years when we have twice as many elderly patients and like half as many workers? It's pretty scary. I mean, in hospitals I've worked in, even recently, like we've had to close parts of the hospital just not having staff, and that's not like something that makes you feel good.
Why is that the case? Is it just because the barrier to entry to becoming a doctor or a nurse is so high and so expensive? And like, if you look at the optionality, if you're 18 years old, you can go be a software engineer and make 300 grand a year, and it's pretty easy. Becoming a doctor is very hard.
Yeah.
Is that the reason, or are there other factors?
And I would say like the day-to-day of being a nurse is like even harder. Just like the availability of different types of careers and jobs, and especially with the gig economy. So, like being a nurse is, I think our product is developed by a doctor and a PT, but it's really used by nurses and physical therapists and patients. It's a full contact sport. I mean, nurses, as doctors, we're not always exposed to things, but nurses, they're at the bedside all the time. There are so many things that they have to deal with for patients, whether it's like agitated patients or cleaning them. It's not easy on your morale or on your body. And I think nowadays, I think in the 60s, you look at healthcare jobs, it's like, this is like a stable living to buy my white picket fence and house. But nowadays there's so many other jobs that you can have out there. So I think part of that is people going into those jobs. I think a lot of it was actually just a lot of the older nurses retiring and us not necessarily as a country, like not preparing enough for that, right? There were a lot of nurses that were on the brink of retirement, and then COVID happened and they basically said like, I'm out. Like, I don't want any of this. Like, I'm going to retire a year early, and you can't blame them, right? It was a crazy time. But yeah, just to go back to your question, like why hospitals, they recognize that, bed flow is an issue. It's a top 3 priority for every healthcare system. There was a president of a large healthcare system that one of which we kind of had some contacts in, and he said, yeah, they literally went to their shareholders meeting and said, this is our number 1 priority is mobility, because it impacts everything from operations to finance to costs to staff. So yeah, I think recognizing that they need what's being used now, the old model is never going to work. It's going to actually be more, short staffed. And so you need something that's more scalable.
Makes a ton of sense. You guys sell directly to hospitals then? You're not selling through other channels. When you go to a hospital, like what is the incentive structure for them? It sounds like the incentive is pretty clear, which is you guys go and say, hey, if you implement our technology, you can get patients discharged faster, opens up more beds. Is it that simple?
Yeah, yes and no. Like selling into hospital systems is in many ways like a death sentence or perceived death sentence for startups. You Google it and it's like 12 to 18 month sales cycles. I think for us, it's been about 2 to 3 months from first conversation to like contracting. And I think that's just because like we are the people that are managing this in our hospital, and the people that we're selling to are like our colleagues. So like on our team, we have doctors, physical therapists, nurses. And I think it's just we want to stay close to the product and the customers. Our value proposition is like a three-headed monster. So the first one is just improving outcomes, which benefits patients, hospitals, and the bottom line. I think it's in healthcare, like one of the things that I feel lucky for is that like I do work in an industry where if I do my job well and I make things better, generally it's good for everyone, right? Like there's not someone that's like suffering because of that. And for us, the triple bottom line is like better patient outcomes. They recover faster, they get to go home faster and have that autonomy of not being in the hospital, which I don't blame them. It's good for the workers. They have less burnout, lower workload, just less things that they have to do. And then better for the hospital, both financially and operationally. So more beds equals more patients, admissions, and more revenue. And so I think it's a three-headed monster. So that's the first head, is just like better outcomes financially, patient-wise. The second is the workforce automation part. And so just like being able to automate some of those things that like their now much more limited workforce can be more efficient and hopefully productive. And it's like there are so many little tasks that nurses are tasked with doing that are not intrinsically part of their job. Answering phone calls from families to know how their patients are doing. Did my mom get out of bed? Answering questions, patient education. So we try to automate all that for them. And so they can just focus on like nursing. And then the last, I think, head of the monster is data. Mobility is a component of a lot of things downstream in the hospital that affects their bottom line, from discharges to where patients go to readmissions and bad outcomes. And right now in hospitals, it's not really tracked or quantified very well. You go to any hospital, like they know a ton of stuff about like sepsis and heart attacks and strokes, but mobility is kind of this like more benign thing that, it's like the way that people know about how much mobility a patient has had is like looking through the notes, talking to like nurses from the day before, very like non-reliable methods. And so we use the computer vision to provide a automated, scalable, and very like accurate measure of mobility that hopefully hospitals can plug into, where one day if you have a patient who's 80-year-old and has these medical problems and can't move this side of the ground, with our data, you'll know exactly like what regimen to put them on to get them home.
It's awesome. Makes a ton of sense. And for healthcare systems that are buying the technology, like, is there a measurable ROI today? Is it clear that if you spend $1,000 of the technology, you're going to save $10,000?
Hopefully with us, you'll save $100,000. So we're actually shooting for an ROI of like 100x. So basically, I think if you look at like, Medicare data, CMS data, AHRQ data, the value of an average hospital admission, like being able to put a new patient into that bed, is about $15,000. And that's a weighted average that's weighted between medical admissions and surgical admissions. So medical admissions reimburse less. Surgical admissions like a hip, a shoulder, heart transplant, those reimburse like magnitudes more. And so $15,000 is about the average value of like a bed for admission. And so for us, our ROI and our pricing right now is that for if even one patient out of 100 patients using us goes home one day sooner, you're going to break even. And so that's a 100x ROI. And I think we're okay with that because like any startup in the beginning, you're trying to get eyeballs, you're trying to prove your outcomes. And I think we command more than 100, more than that amount of value. But I think we're trying to get in patients' hands and just prove out the ROI first.
It's incredible. And if we zoom forward 10 years, let's say in 10 years, you guys have saturated the market. Every hospital has your technology in the bed. What's the broader vision? What's your second act once you've conquered the primary use case?
Yeah, I mean, hopefully if that happens, you and I will be having a different conversation. The goal for us, when you're a clinician and you see patients, you see people suffer and you're the one that is like tasked with fixing them, like you want to just do it to fix the problem, right? Like nobody goes into medicine and goes to residency to be like, I just want to collect a paycheck. Like they're like, no, I want to like save people's lives. I want to get them better. I think our goal would be great. There are 6,000 hospitals in the United States. We'd love to be in all of them, in 10 years. However realistic or not realistic that is. There are some health systems that are analogous and similar, Canada, UK, Taiwan, that like, they're elderly, like the aging epidemic is global. right? Like you look at countries like Japan where their age demographic has inverted, where now like they have way too small of a younger class to sustain the large population of geriatric patients. And so the goal would be to like, be in as many patient hands as possible. And that's not so much like in a way that to conquer the world or anything, but I think it's just, I want to be able to make people like me, like do their jobs easier, right? Or like nurses, doctors, anyone who works in a hospital, like they sacrifice a lot to take care of patients. There are countless days where we stay behind after shifts and we're not paid because we're trying to do the right thing and like stabilize a patient, stay behind to like make sure that like a family member understands what's going on. And so like just anything that we can do to make their lives, make them do their job easier is maybe one extra nurse that stays in the workforce. I think that like it's not lost on us that there are opportunities for both horizontal and vertical expansion. So I think for us, the hope is that, if patients are never more invested in their care than when something bad is happening, right? So that guy that's been eating donuts for 10 years, the day that he's having a heart attack and having chest pain, tell me whatever, I will do whatever you want me to do. And so, our hope is to kind of take advantage of that opportunity to kind of engage patients during their acute illness and help build good habits. Hopefully, if they build good habits in the hospital with physicians, and people that they trust, then those good habits will stick with them and either they'll use us or they'll use another platform. But I think hopefully that familiarity helps us. And then I think from a horizontal expansion perspective, looking at different functions is, it's not lost on us that if you have the engagement of a patient at the bedside, occupying that real estate is extremely valuable because in a hospital, there are probably 15 hours in the day that there's nothing to do. And if you're the only thing that a patient can engage with, that opens up a ton of opportunities for not just enabled health and strength and conditioning, but also patient education, nursing communication, teleconsults, updating families, finding new products. And so I think there's an enormous opportunity to build an ecosystem and a marketplace for other functions that patients and providers need automated at the bedside. In the beginning, you're just trying to stay focused and build out the one thing.
Absolutely. So I'm going to ask you two variations of the same question. I'll start with the first version. You've been building this company. Obviously, sure, you've learned a lot in the process. If you could go back to day one of founding the company after everything you've learned, what advice would you give yourself?
That's an interesting one. I think probably don't get too high and don't get too low. I think like staying even keeled it's hard to not do that. I think I remember that day because I actually was close to having an offer to go back to McKinsey to work in their healthcare practice. And it would have been a very great job, but I think I randomly got an email from YC and it just spurred this. It literally was like that night. And I think it just got some things going. But I think just remembering that like, not getting too high, not getting too low, it doesn't do anyone like a service. The sun will rise the next day. One of the podcasts that I listened a lot to was like Startup Therapy, which is, I think, created by Ryan Rattan and Will Schroeder from startups.com. And that really helped me just because, like you talk about like mental health, but like some of the most high intensity jobs are not really like included in that. And so there's a great startup out of YC that does like mental health only for like physicians and nurses and healthcare providers, where the therapists are other healthcare providers. And I think there are just certain high intensity jobs where, some things like PTSD, if you're a police officer or a firefighter, you need to talk to other people in your field who get it. And so I think just listening to that was really helpful to kind of not get too high, not get too low, and visit like the emotional issues. Because ultimately, like if you are the car and you have to travel 100 miles, like the emotional balance is what kind of, it's like the gasoline in your tank. And you have to maintain that.
It's fantastic advice. And I don't think people realize how hard it is to build a company until you try to build a company. It's all encompassing. And yeah, I think more people should try to balance the highs and the lows, right? It's one day you wake up and you have the best news in the world and you get punched in the face. And it's just like this sequence of getting punched in the face, falling down, getting up, having a great day, getting punched in the face. And you do that on repeat until you turn around and have a $30-40 billion company. So that's great advice.
Yeah, that's exactly what it is. And like, it's funny because this morning I went to like a kickboxing MMA like gym where I work out. My father-in-law did some kickboxing growing up, and like when we spar, I literally ask him, I want every session to be like, you punch me in the face 60 times so that I just get used to it, and then we can start sparring. But
Yes.
I'm kind of reluctant to do it.
Man, it's funny. Go back to the beginning of the conversation. You said that like the best athletes in the world are just crazy and they're just different. I think getting punched in the face 60 times voluntarily might put you more in that camp than in the camp of a normal person. But putting that to the side, I guess the second variation on my question, and the answer might be the same. If you could go back to your first day of medical school, learning everything you've learned through that process, through residency, becoming an ER doctor, what advice would you give yourself?
I wouldn't do anything different. Like, it's been an amazing ride, and I think like I think you always hear about parents like telling their kids to not go into medicine, and I understand where they're coming from. Medicine is changing, and it's not fun when you are having trouble adapting. Like, my mom is a physician, and I think watching her like navigate some of these things like documentation, like it's a struggle. But I would say it's a extremely gratifying job to be trusted with taking care of people's lives. It's something that I would hands down do for free if I had the time. Who doesn't want to be a part of a team that like saves someone's lives, right? Like, that's like real life Avenger stuff. And I think just like being around good people, people who genuinely care about patients. And I would say like the biggest thing I would probably tell myself are that like the habits, like to resist the urge to build bad habits. Because I think when you go through things that are hard, you're so like in medical school, there are nights where you haven't eaten, you haven't slept, like you have to study, and like you just, all these basic human needs are depraved. And I think there's a lot of incentive, and I tell this to my residents that I train, is like there's every incentive in the world to develop a bad habit and to cut corners. But I tell them that like the habits that you develop during residency are the habits that you're going to keep with you for the rest of your life. And it's not like a habit of eating ice cream at night. These are habits where like something bad will happen to someone and someone's family member. And so it's like you really have to fight the urge to just like do the right thing, as cheesy as that sounds. Because if the whole point of doing this was to have positive impact on people, then like that is worth that extra effort to maintain a high level of quality. But it's not easy. I work in a system where most health systems, everything that someone doesn't want to do gets pushed to the ED. Like, if a specialist doesn't want to see someone, they have them go to the ED. And so maybe I'm a little bit like, particular in that, but it's still, I think that trying to build good habits. Yeah.
Great advice. So if people want to follow you, follow the journey, where should they go? Twitter, LinkedIn, Enabled's website?
Yeah, all of the above. They can go to enabledhealth.ai. They can email me at thomas@enabledhealth.ai, or just go to our website and send us an inquiry. Any hospitals out there that are struggling with mobilizing patients, not having beds, struggling with workforce, which I think unfortunately is every hospital, like we're more than happy to talk with you, talk about doing a pilot. And yeah, and well, I really appreciate getting the chance to come on here with you and Max. Like I've been a big fan of ARC for a long time. I appreciate people who are looking into the future, and I appreciate you for hosting me.
No, great having you, Thomas. Thanks for joining.
Awesome. All right, take care.
Thanks for tuning in to the Autopilot Podcast. If you're using AI to create or disrupt a large industry, I would love to learn more about your story. Drop me a line on Twitter or go to our website, apv.vc. If you want to support the show, the best ways are to leave a review wherever you're listening and subscribe. The Autopilot Podcast is part of Turpentine, the podcast network behind Moment of Zen, Turpentine VC, Age of Miracles, and more shows for experts by experts in tech.